which is surgery. I see Stephen Price, that's already encouraging. Hopefully we will also hear you in a minute. Stephen Price comes from the UK, from the Department of Neurosurgery in Cambridge. Thanks, Stephen, for making it and for dialing in this at the right time, although you are living in a different world.
Thank you. Can you see my slides?
Yes. Yeah, sure, it's all good.
Brilliant, great. Thank you very much for the introduction. So I'm Stephen Price, I'm a neurosurgeon from Cambridge. I'm going to talk a bit about reoperation for glioblastomas, and I really want to focus on really an honest appraisal of reoperation for glioblastomas. And thank you, Michael, for the warning. Actually, I think I've got my last slide to answer your question. They're my conflicts of interest to declare. So this is the standard thing we see. This is a patient who has presented with a seizure, had a enhancing lesion seen on the MRI scan, goes for surgery, has a complete resection of the enhancing tumor. Histology comes back showing this to be a glioblastoma, goes on for radiotherapy and concomitant and adjuvant temozolomide, and then on follow-up imaging is found to develop new lesions. This patient was completely asymptomatic, did not have any other symptoms, and had these lesions here. And the question is really, what do we do about this? And is this something we should be thinking about for surgery? So what do the guidelines say? Here's the IANA guidelines. So typically considered when patients have a large but circumscribed lesions causing neurological deficits. Well, this lady's obviously got some lesions. They're relatively well circumscribed, but she's not got any neurological deficits. And the interval between surgeries is more than 6 months, so that will fit in with that. What other guidelines are there? So this is the UK guidelines, the National Institute of Clinical Excellence, the NICE guidelines. And in this, it shows even less information for us. It says this is an option we can think about in patients that have got focal recurrence of a high-grade glioma. And this is where the problem is, and there is real problems with the literature looking at surgery for at progression, because virtually all of the studies are single-center retrospective cohort studies. There is little comparison with patients not receiving surgery. I'll show some data on some of the studies that have perhaps looked at this. There's a lot of selection bias, and I'll talk a lot about that, about patient selection. And in the modern world of molecular markers, there really is nothing about this in terms of guiding us for surgery and what we should be doing for surgery. So what I want to cover in this short talk is a bit about patient selection. I'm just going to touch briefly on some of the surgical nuances, talk much about the outcomes and complications, and at the end I just want to sort of tie things up together and talk a bit about how we can balance these benefits and risks of reoperation. So let's just think about the patient selection to start with. So what sort of patients are suitable for reoperation? Well, this is where things are very difficult. If you look to the literature, there is a very large range of patients who would be considered and would be having reoperations, going from 5% up to 40%. And this is largely because of the fact that there is no consensus on which patients we should be operating on. And there certainly is also thought to be a bit of a variation by nation, and certainly us in the UK, we seem to be on the lower end of this range. Just to sort of show the difficulties that we have with these patient selection, supported by this paper that was published just last week in Journal of Neuro-Oncology led by Paul Brennan. And this was a questionnaire that was sent out across the world, and it focuses mostly on UK and European practice, but there is some aspect of this that will cover the rest of the world. And as part of this, they also asked the UK centres to provide some retrospective data from their own units, so they could answer some questions about outcomes. So the first and most basic thing we have to be able to deal with is working out, has the person had a recurrence? Is there evidence of tumor progression? And the majority of units that were surveyed said that they would follow patients up with regular MRI surveillance. In most cases, we are detecting, we would aim to detect progression before patients become symptomatic. And most, obviously, contrast enhanced T1 is the standard of care for this, but other advanced MR techniques and even PET techniques were being used. And this is really quite important, obviously, to show that there's clear evidence of progression. The second part of it is the discussion then in a multidisciplinary team or a tumor board to come to the conclusion that we should be continuing with surgery, and this is really to make sure these patients are suitable for further treatments. And this is done very well in Europe, not so well in the UK, and is an area that certainly many places are looking at trying to improve. So is this progression? So this is an example. This is a patient actually we discussed in our tumor board last week, and a patient who had a glioblastoma resected now 18 months ago. And for the first time, we are now seeing this dot of enhancement. We can see arrowed there in the front of the resection cavity. And there's a question about somebody who is completely asymptomatic of whether we should be looking at going back in and re-resecting that at this stage. In fact, we've decided to just watch this very carefully, but I'm certain that at some stage we will be reoperating on that. Okay, so let's look at some of the factors that determine patient selection. What about patient age? Well, in this survey, just over a quarter of patients thought that patients over the age of 70, patients over 80 were unsuitable, and a further quarter thought that patients over the age of 70 was the cutoff for operating on these, for reoperating. Although about 45% of patients said it did not affect their decision making. What is interesting, if you look at the cohorts and also other studies, is that the median age at reoperation is usually much lower than for primary surgery. So this is part of this issue of we are selecting patients that we think have got better prognosis for surgery. One thing I have learned over the years of doing neurosurgery with patients that are, say, for example, in their 80s, that everyone says looks like they're much younger than that, is that there is nothing like a neurosurgical operation to prove your birth certificate is correct. And we do find a lot of patients, I've certainly found a lot of patients who you've said, oh, this patient looks amazing at 82, you do an operation and then they don't get out of bed after the operation. And that causes real problems. Performance status, well, most people said that the aim of surgery will be to maintain the quality or improve the quality of life for these patients. And this is where the Karnofsky performance status, there's a variation in what people would say. Most people would insist that patients had a degree of good performance status. So this is certainly over 70. In other words, they are self-caring. But there was a group of people who would not use this to influence their decision making. The time from surgery is really quite controversial. Although many people would say that they would not consider surgery if the patient was still in the phases of the primary treatment, in other words, still in the adjuvant phase of the temozolomide. And a lot of people think that the time from first surgery is important. There was really no consensus about what that should be. And in the study cohort, this was again a longer period of time than we would normally see, of 13 months between the two operations. And again, this brings in a problem of selection bias. And this is really quite important, this whole business of selection bias, and this is an example of it. And this meta-analysis published a couple of years ago is a really nice example of showing you how this is the case. So if you take the time to first surgery as a fixed covariate, in other words, you fix it to say 10 months or another time point as a fixed covariate, then you find that surgery compared to no treatment provides a better overall survival and a better post-progression survival period of time. In other words, a period of time that from that progression onwards. But if you then take it as a time, what they then did was they then reanalyzed their data and looked at this as a time-dependent covariate. And when you look at it that way, you find that there is no survival benefit. And this again just shows this is because of the selection of this group of patients that you would expect to have a better prognosis anyway. what do we think as surgeons about how much of the tumor we can resect? Well, many people felt you had to resect more than 90% of the contrast-enhancing tumor. A group that thought that the extent of resection did not really influence decisions. And there's little evidence out there to direct us on this. One of the best bits of evidence is the Directus trial. So this was a trial that was really designed for looking at the efficacy and tolerability of two temozolomide regimes at progression, but they were able to perform a sub-analysis that looked at the impact of extent of resection at the first progression. And in this study, they had a cohort of patients that had no further surgery and a cohort that had further surgery. And of those patients that had surgery, some had complete resection, some had incomplete resections. And when you look at whether they had surgery or not, you found there was no difference in the time to the second progression, nor was the post-progression survival period altered at all by this, by whether the surgery was present or not. What was more important was the quality of surgery. So if you have a complete resection of the enhancing tumor versus an incomplete resection, you find that the complete resection provides a significant improvement in the time to the second progression, but also the total post-progression survival. And interesting, if you compare the group of patients that had an incomplete resection versus no surgery, they found no difference between the two groups. So this really would suggest that the better the resection, the better the quality of resection, the better the outcome for patients. And this is an example of a patient. So this is a lady who presented with some speech problems and had an awake craniotomy, and we managed to do a complete resection of the enhancing tumor. The frontal tumor again came back as a glioblastoma, MGMT methylated, went on to have treatment, and then some months later has progressed. And her progression is now adjacent to the resection cavity, but as you can see, it's going into the corpus callosum, it's going into the opposite frontal lobe, and in fact, I haven't shown it here, but it's going down and it's invading the septum pellucidum quite widely as well. And on the basis of that, we have decided that we have not decided to reoperate on this lady because we don't think we can resect all of this tumor. So the Brennan group have looked at this and tried to come up with some guidelines or some proposed selection criteria. And these really are based on opinion and really have no real evidence that are behind them that shows that these are the criteria that we should be using for these patients. Okay, let's just talk. I'm just going to briefly talk a bit about some of the surgical nuances and some of the information that we need that would be very useful when we are thinking about considering surgery. So this is an example of a 70-year-old man presented with some limb weakness and had a resection of this what turned out to be a glioblastoma, and in the gyrus directly behind the tumors where with neurophysiology we could stimulate and stimulate motor function. So we have an idea of where the motor areas are preoperatively, and now he's progressed in the quite some months after his original surgery, and it's in a more of a lateral position. So we know that from his previous surgery, and because we have kept very good records of where we found functional tissue and that we know which areas we should where the areas of concern are, and we feel this is an area that we're less concerned about, and that we would be able to offer surgery and be able to resect that the area of new contrast enhancement. And that is really important to understand that. There is some evidence in low-grade, quite a good evidence coming out now in low-grade gliomas that there is a degree of plasticity and that functional areas can, to some degree, move around tumors. The issue we have with glioblastomas is we've never seen that. There is no evidence of that. And the other thing about it in this cohort of patients is that the time interval between the first two surgeries is probably not long enough to see significant changes. What about adjuncts we might use for surgery? So 5-ALA is used now fairly routinely in our practice for this. And this study by Irina Barbi a few years ago now, looking at the ability of 5-ALA to predict and identify tumor from looking at different biopsies. The predictive values are well in the 90s. So this is not far off what it is in a first off surgery, suggesting that it's actually quite good for and could be used for guiding surgery at the time of progression. Other adjuncts that could be used, so intraoperative neurophysiology, we use quite a lot, and we haven't really found any differences using it in the first surgery versus at progressive surgeries. Awake craniotomy again is very useful. The one issue we've seen in a couple of patients is where you have the dura sticking to the becoming very adherent to the cortex, and no matter how carefully you are dissecting it off, you always cause some degree of injury to the cortex below it. And I've seen at least 2 or 3 cases where patients have woken up with speech problems because of just trying to get the dura off the cortex. So that's something we have to be careful about and be very wary about. Okay, let's look at outcomes for these studies. So this was a meta-analysis of a number of these, again, are all single center retrospective cohort studies on the whole. And what this study looked at was compared the outcomes for these group of patients that had surgery versus those that did not have surgery, but still both groups went on to have other treatments from it. And you can see that from this graph that the direction on this forest plot is towards benefit from surgery, so an improvement in outcome with these patients having surgery. What about quality of life? We said that the aim of surgery is really to maintain quality of life, and this is a paper that came from St George's Hospital in London, and this looked at quality of life, and what they've used is the SF36 as a measure of quality of life in this study. And what they found was that if you compare the 2 groups, those that had surgery and those that didn't have surgery, preoperatively the baseline is very similar, but at 4 months the group that did not have surgery had a greater deterioration in their SF36 scores, really across the board. And in fact, if you compare the scales aren't the same, but if you compare the 2 scales, you see that there's actually some improvement in the scores in the those that went on to have surgery. So how much progression-free survival do you get after a second operation? So this is data from Cambridge. So my fellow Suma Mukherjee has gone through the data from all our surgery for all the GBM surgeries we've performed over the 5 years, and looked at the progression-free survival interval following surgery. And what he found is after the first surgery, the progression-free survival was over 16 months. And on the second surgery, it was down to about 8 months. And this fits with certainly what sort of an old adage that I certainly was taught, is that every reoperation gives you half as much time before progression as the last one. Complications. Although surgery is obviously very good at resecting tumors and removing, and it's one of the best ways of killing off tumors, it is still by far the most toxic of all the therapies we use for treating patients with brain tumors. And this is the data that Suma that Cho got for us of the Cambridge data, and you can see very similar data in terms of neurological deficits, but where the difference was in terms of wound infection rates. And the wound infection rate increases quite considerably in the repeat resection group compared to those at primary surgery. And this is the major cause of why these patients will have complications. If you look at the Brennan data, they found exactly the same thing. There wasn't much of a difference in the neurological deficit rates, but you do see an increased rate in non-neurological complications. And their data also looked at the infection rates between first surgery, second surgery, and third surgery, and these are increasing for each operation you have. And the issue with developing an infection from these patients is frequently they will require reoperation or washouts. They will often require things like bone flaps being removed for deeper infections. They will then go on to have 6 weeks worth of antibiotics, usually intravenously for a large part of that. And many of these patients will then be denied chemotherapy or be able to start chemotherapy in a timely manner because they will have to spend so much time recovering from these infections. There's also seems to be an issue about vascular injuries with these patients. And this is an example of a patient that I operated on quite some years ago now. It originally had a low-grade glioma, it progressed, and I was doing the 3rd operation for this. And it was predominantly within the temporal lobe, and we aimed just to take the tip of the temporal lobe out, and just using standard microsurgical techniques where you stay subpially, so you keep the pier between you and any vessels. We were able to resect the temporal lobe, and as part of it, you could see the middle cerebral artery, but it was absolutely covered in atheroma. It was very, very atheromatous, and either because of disruption of that or because of vasospasm, he ended up with infarcts post-operatively, which left him with a hemiparesis. And again, another patient who we have not done any favors for, and his outcome will be adversely affected because of this, despite using techniques to avoid any injury to the vessels. So what I want to just finish off with is just talk a little bit about balancing the benefits and risks, and think about this as a bit of a practical guide of how we may go forwards and with our patients. So just to summarize what I've said so far, the rate of re-resection is very variable, and that's probably because there is no clear patient selection criteria. And the patients we do select are better patients. What we do feel is that these patients would be suitable for other treatments, and you could almost think of surgery as an adjuvant treatment in this setting. We know that there is some, not great quality, but some data that suggests that surgery may delay progression, and it may be about half as much as the first surgery. And some data suggesting that it probably will need a complete resection of enhancing tumor. But that is at the expense of having higher complication rates, especially infections. So how are we going to use this information when we have a patient in front of us? Well, this is the whole business about shared decision making, which is defined as a process in which clinicians and patients work together to select test treatments and management based on clinical evidence and the patient's informed preferences. And as part of this, we have to think about how we're going to provide evidence-based information and to patients in a way that they will understand and can use this information. And this is just an example of one idea. The concept of this comes from has been used a lot in cardiac surgery, where you think about, okay, this was what happens if you do an operation. This is what happens if you don't have an operation. And then you think about 3 scenarios. You think about what is your best possible outcome? What is the best? What is it you really would love to have? What is your worst possible outcome? And what do you think the likely outcome is going to be for most patients? And providing it in a way that patients can look at it and take this information in and make decisions about what treatment options they wish to have. Now, to answer Michael's last question about evidence for this, as I've said all along, the evidence is not great. The evidence for these patients is based on small series of retrospective data. But this may be the one opportunity we might get some information from it. This is a study that's been run by Philip Schutt. It's the research study, the randomized trial of surgery for glioblastoma. And the aim here, the primary objective, is survival following reoperation versus no surgery, and in both groups going on to have adjuvant therapies. Secondary objectives will look at things like other survival outcome measures like progression-free survival and quality of life, as well as safety, and looking at the degree of crossovers, the number of patients that will actually go on to have, that randomized to one group will go on to have the other group. The issue, as you can see by the recruitment graph next to it, is that this has been a very difficult study to recruit to. Although these managed to get lots of centers involved with it, the actual number of patients recruited has been very slow, because most people seem to have an idea of what they will do now. When there is lacking evidence, people come up with their own concept of what they wish to do in terms of their treatment. And I think this is what has happened in this situation. So I'd like to thank you, and thank again the organisers for inviting me, and invite you for any questions.
Trial by by the colleagues from Bern. Zurich, for example, has not been able to put a single patient on. So we are among the failing centers. I didn't hear you say the trial was unethical. This is something we have heard from many neurosurgeons around the world.
So my personal view is that I think one of the difficulties that people use when they think about trials and surgical trials is they keep using the term equipoise. And equipoise sort of implies that you really don't know whether this is better or worse treatment for a patient. I think a better way of thinking about it is uncertainty. We don't know if it's better. The quality of data we've got is very poor. The morbidity is increased. We know that following surgery. So from my personal perspective, is I think there is actually enough of a uncertainty that this would be a valuable trial. So I personally would not say this is an unethical trial.
Thank you. Maybe we will have more questions later on. I will have another one for you. So you mentioned the sub-analysis of the director trial. Thank you for that. And director obviously triggered the research trial. On the other hand, looking back on this analysis, I sometimes wonder whether we have not simply misinterpreted the data to say that a resectable tumor at recurrence is simply a different disease, and the causal link between the complete resection may not be that valid. I'm just wondering whether resectability is a biological feature as well.
Yeah, I think you're absolutely right there, and I think that will impact on patient performance. So the tumors that are sort of less resectable will be the ones that are deeper, possibly larger and nearer to eloquent areas, and they're the ones that are more likely to cause neurological deterioration. So I think there is certainly an element of it there, and all these small studies have shown that there is very much a selection bias in terms of the people we operate on, the people we offer surgery for, are the ones who've got the better prognostic features.
Yeah, thank you very much. I still have no question in the chat. So you have a break now. Maybe there will be more questions later. And now Elizabeth will take over for the moderation.
Maybe I have a question, a provocative question. Do you in your practice associate resurgery and then if there is a residue, reirradiation after your resurgery?
Well, reirradiation is something we always consider amongst our patients, whether or not they've had redo surgery. I would love to say that in our practice we have very few patients that would have residual disease after redo surgery, but that's probably not true. It's something we certainly think about. It's always a consideration for patients.
Okay.